Welcome, everyone. Just going to let everybody's audio connect and then we'll get started. Well, we would love to welcome you all to our special webinar with Pat Deegan this afternoon on the role of peers within clinical teams. Patricia E. Deegan, PhD, is the founder of Pat Deegan and Associates. For over 30 years, Pat has, sorry, Pat has been a thoughtful leader and a disruptive innovator in the field of behavioral health recovery. Pat founded a company run by and for people in recovery. The mission is to safeguard human dignity by bringing individual voice and choice to the center of clinical care teams. Toward this end, she developed Pat Deegan's recovery approach that includes the award-winning Common Ground software, medication empowerment, certified personal medicine coaching, and online recovery library, the Common Ground medicine, the Common Ground approach. She also has developed the Hearing Distressing Voices simulation. And since 2009, Pat has worked as a consultant, helping to develop and evolve the On Track New York model for coordinated specialty care teams for young folks experiencing early psychosis. Pat is an activist in the disability rights movement and has her own lived experience journey of recovery after being diagnosed with schizophrenia as a teenager. She has held a number of academic appointments, has numerous publications, and has carried a message of hope for recovery to audiences around the world. She received her doctorate in clinical psychology from Duquesne University. Welcome, Pat, and I'll hand it over to you. We will be holding questions until designated times in today's session. So if you have questions, feel free to use the chat feature and we will help to get those answered during the Q&A time. Pat?
Oh, thank you so much, Cami. And thank you, Washington Healthcare Authority, for this opportunity to talk with you all today. Let me just start by thanking you for what it is that you do. I think the work we do can be very challenging and it can be profoundly rewarding at the same time. And I always get a little weepy at this. This is really important work that we do, and it matters a lot. And that I personally want to thank each and every one of you for finding it in your hearts, in your passion to prioritize this work and to know that when I was a kid coming up, I received the message that I was going to be sick for the rest of my life, and that schizophrenia was a chronic condition, and the word recovery didn't even exist and in relation to schizophrenia. And I believe that we're turning the tables on that message. Slowly but surely, inch by inch, we are turning the tables. Young people working with us these days, and even older folks these days, are getting a different message. And that is, it is possible to get to the life that we want. And that it's not necessarily about being compliant. It's about bringing ourselves to the healing equation and co-creating health with your expertise involved with us together moving forward. So I know that the big secret in the rooms that we spend a lot of time in here in behavioral health is that, yes, we have people that we say have the lived experience of their own recovery, and then there's the rest of us. And that I know that the reason you can do this work is because somewhere in your own life, you have made a very difficult passage. You have encountered that point in time where life came along and knocked you right off your horse, knocked you right over, right? And we even have had the experience of, I don't know if I'll ever get past this. It could have been the loss of a child or a miscarriage. It could have been, growing up in an alcoholic home. I don't know what your passage has entailed. But what I do know is anybody can come into behavioral health and last for 6 months, 7 months, right? Right? But we stay. And the most important question is why? Why did you show up at work today? And in order to show up, I think we need to have our own sense of our answer to that question, our why we do this. And that I know because at some point you have made a passage, came out the other end bearing a gift. And I believe that gift is a gift of hope. The rest of society avoids people with serious mental illness, FYI, right? We're a marginalized group, and yet we're here to work with folks with these diagnoses, right? And it's because I think we know that it is possible to work with people in a way that helps them rebirth their own lives and move into a better life. And that is the enduring hope that we carry. And it's an indefatigable fire within us, as Dr. King would talk about. This fire cannot be put out, no matter how big your fire hose. All right, it's within me, it's within you, and I know it, and I thank you for it. And it really matters, and we don't hear it enough in our work. Today, what I'm going to do is I like this particular presentation. I think it's really good. And we're going to look at the question of what exactly does a peer specialist do on a clinical team and why is it important? And I consider this particular webinar to be as important for peer specialists as it is for colleagues as well on the clinical team who themselves are not in the peer specialist role. So again, thank you, and I'm going to get us rolling and bring up that old PowerPoint. Okay, I am going to share this, and here we go. So, I think these days, when we think about peer support, we think about it as a profession, as a paid position. And of course, that's a great accomplishment, and peer support has come a long way. But it's important to remember that historically, peer support has just been a natural occurrence between those of us who've been diagnosed with mental health challenges for literally for centuries. So I define peer support in this sense as, and I think it's the most basic definition of peer support, is that it's love freely given. That at its core, peer support is about love that is freely given. And much of the peer support that has happened for centuries now, as I've mentioned, it's really never been spoken. It's never been raised up and it's never really been celebrated. This more informal, unpaid, love freely given peer support. It's natural. It happens because we are human. And I want to raise up and celebrate one example that I'm particularly fond of. This is Miss Jenny Fulgham. And I met Miss Jenny back in 2003. My friend and colleague Vanessa Jackson and I were working on this amazing project to begin to tell untold stories, including the story of racially segregated asylums in the United States. And as part of that, we wanted to get first-person accounts and have an opportunity to talk to our peers who had survived these asylums. So we met the woman you see here. Her name is Jenny Fulgham, and at the time she was an 81-year-old African-American woman, and she lived in a small town called Zuni, Virginia. And way back in 1947, she was admitted to the racially segregated Central Hospital in Petersburg, Virginia. And she was diagnosed, not surprisingly at the time, with paranoid schizophrenia. And after discharge, Miss Jenny went on up to work for the phone company for about 20 years in New York City. And in many ways, her life resembled the lives of other people at that time. However, Miss Jenny never forgot her experience of being locked away in the institution. And especially, she never forgot the people that she left behind when she left the institution. So, in 1961, she and another former patient, they get this van and they begin to visit and, as she put it, encourage other patients at New York City's mental institutions. Again, unpaid, no contracts, no benefits. She just does it, right? And then in 1978, Miss Jenny returns to her rural hometown and established what she calls the Zuni Federation for Mental Health. Miss Jenny single-handedly cleared and leveled 3 acres of her own land with nothing but a shovel and a wheelbarrow, and she establishes on this land the Garden of Hope, which was a retreat, a spiritual retreat, where former patients were welcome to spend time, to relax, and to get in touch with nature at no cost to those individuals. So for me, Miss Jenny embodies the true spirit of authentic peer support, which is, again, love freely given. So, inspired by Miss Jenny, I want to suggest that let's understand that as peer specialists, part of our heritage is that we plant gardens of hope in the hearts of all of the folks that we're working with. But Miss Jenny, interestingly, was not the first person or the only giant upon whose shoulders we're standing today. In fact, our history, even of organized peer support, goes back for centuries. For instance, there's this amazing story of a guy named John Thomas Percival from the United Kingdom. And after serving in the military, John Thomas Percival was committed to 2 private asylums in England between 1831 and 1834. And upon discharge from the asylum, Percival published 2 books describing his passage through madness and the horrors of the treatment he received. He writes, I reflected on how many were in the same predicament as myself. And I said, who shall speak for them if I do not? Who shall plead for them if I remain silent? How can I betray them and myself too, by subscribing to the subtle villainy, cruelty, and tyranny of the doctors of the asylum? When John, who by the way spent 8 months in restraints, not unlike the ones you see here, when he gets out of the asylum, right, he forms what he calls the Alleged Lunatics Friends Society. And this organization uh, was up and running between 1845 and 1863, right? Nearly 20 years. And actually, the Alleged Lunatics Friends Society had up to 60 members. And that here's a poster that has actually been photographed from the day that his organization would put out a public lecture on the reform of the laws of lunacy in the UK. And what's interesting is that the alleged lunatics, some members were persons themselves who had not been in asylums, but who felt a solidarity with the alleged lunatics. And together they would organize like clothes drives. They would make sure that patients in the asylums were getting mail, were getting special food, and news of the outside world, which at the time was a really unprecedented act. So again, we see this kind of act of love. In this case, different than Miss Jenny's in the sense of this was an organized effort that somehow John Percival was able to ignite the passion and demonstrate the leadership that others felt emboldened to follow him. And so the way I see it is that peer support at its core is and always will be occurring at the intersection of love and outrage. It's about love freely given, unpaid, like we saw in the example of Miss Jenny. And it's also an example of outrage, the outrage that John Percival felt and the moral obligation he felt to reach back out to others, in his case, through his activism, his demand for system reform of the Alleged Lunatics Friends Society. So when I bring it up to date now, in more modern times, there is a very mistaken understanding that peer support, modern peer support, um, came from self-help groups for medical conditions, and in particular, some of the earlier medical conditions patient support groups, patient-to-patient support groups, might include the American Cancer Society support, multiple sclerosis, Parkinson's, etc. But interestingly, this is not where our peer movement came from. Historically, our organized peer movement at its roots and finds its roots in the disability rights movement, in the women's movement, in the civil rights movement, in the peace movement, and in the LGBTQ plus movements. And I want to share with you a brief news outtake clip from 1978 to show you what activism in our movement was like in the late 1970s, for instance. And you'll see some other folks some of you may be familiar with, Judy Chamberlain, Jay Mahler, and others, well-known leaders in the movement. And so this is from 1978, and these folks are having a demonstration in Philadelphia in front of the corporation, Smith, Kline, and French, that created the first antipsychotic medication at the time was called chlorpromazine, or we know it as Thorazine, right? And so they are outside of the corporate headquarters of Thorazine, and they have something to say. So you're going to hear things like, the inmates united will never be defeated. And you're going to hear things like uh, David Oakes giving a lecture to the corporate folks at Smith, Kline, and French. So let's just a minute. Let's just watch it together and enjoy it.
Ex-inmates fight on, fight on, ex-inmates fight on. If you don't feel be sure, they will dig up some cure. So fight on, ex-inmates fight on. Bridgewater, Waterbury, and Fairview, sing. Ex-inmates try to be free. Stop drugging! Stop forced 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 drugging! Defeated! The inmates united will never be 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 defeated!
Those chemicals put into your brain and experienced the suffocation, the draining of all thoughts and feelings because of this chemical, then you haven't experienced the oppression we're talking about.
Okay. Activism has always been a part of the peer-to-peer movement and represents an important thread in our historical roots. And the tradition continues today with our movement creating all sorts of alternatives and demands for rights. And so everything from the more contemporary, called Black Line, Alternatives to Suicide, the Hearing Voices networks, Mind Freedom, these are all peer-run um, uh, alternatives that exist outside of mainstream services that are not funded as part of mainstream mental health, and that continue to represent an effort by our movement in trying to create alternatives to systems that at times can be experienced as oppressive. Now, I think you can feel, okay, if this is where some of our history is coming from, both the love freely given and the outrage, it's an interesting combination. And sometimes that, of course, can create tensions, as we're going to see when we join into traditional clinical teams, right? And so last but not least, let me mention the advent and the beginnings of paid peer support, right? Because it's a relatively new development when you think of the centuries that peer-to-peer stuff has been happening. And the beginnings of the paid peer support model started in 1986 with Colorado Mental Health Consumer Care Manager Aid Program, right? And even the language when we read it makes us cringe these days, but it said, they were going to get high functioning consumers, right, who could take over some of the case management duties, right, and be able to provide role models. In 1990, NIMH gave New York City a grant to begin involving peers in the intensive case management model. By 1993, people like Darby Penny and Celia Brown in New York State started developing and agitating to get the state to create civil service jobs. That's 1993. And by 2002, Larry Fricks and the good folks at the Georgia Peer Network were able to get a Medicaid waiver. And that kind of changed the game because now there was a way to fund peer support services. So, relatively speaking, I hope you can see here that paid peer support is a particular kind of iteration of what peer support is all about, right? And it's a relatively new development. And that's why I would argue that, that peer support is still in a very evolutionary stage as a paid profession. We are still defining ourselves. We're defining our relationship to this much longer history of love and outrage. And, what place does love have in a paid peer specialist work? What place does outrage have in paid peer specialists? These are tensions. And these tensions, as we're going to see, are evident today, and that we need to recognize that these forces are at work once we take a peer specialist position and make it an integral part of a service delivery team, whether that be an ACT team or be a coordinated specialty care team. Dynamics change. Okay, so a simple definition of certified peer specialists. Now, this is the paid profession. Are people who use their lived experience of recovery to support others in reaching their goals for their lives. But what the heck does this overused term lived experience really mean when you get right down to it? What does it really mean, right? Well, the truth is this term lived experience is not new at all. It's been around and was created by a German. He's considered the father of phenomenology, which is a school of philosophy. And his name was Edmund Husserl. And what's interesting with Husserl is that he was interested in what is the world and how do we as humans experience the world before science tells us what the world is all about, right? I'll be telling you more about that in a minute. So he became very interested in this realm of human experience that he sees as prior to science, the realm of lived experience. So when we, in the year 2025, use the term lived experience, we are not creating it. Okay, guys? And I've heard a lot of people say lived and living experience, but I think we kind of don't need to go there. And the reason is because the term lived experience has a long and rich history in the whole disability rights movement. It was first people who were blinded during World War I who adopt the term their lived experience. And they were saying to people during what were called the blind marches in the United Kingdom, yes, I can't see, I don't have my vision, I was, wounded in the service of my country, but I can work. My lived experience is that I can be productive. I want a job. This was unheard of. Okay, but they grabbed this term from Husserl, lived experience, right? And then the women's movement in the 1950s picks it up. The lived experience of women is different than that of men. Imagine, and actually begin to organize using the term lived experience. So this is a term that other marginalized groups have used for decades now, okay? And we're sort of proud next steps in that tradition. But really, beyond fancy names like phenomenology and founder of phenomenology. What the heck is it, right? Well, simple example. In like the third or fourth grade or so, we were taught in a science class that the human heart is a biomechanical pump. And the heart of those little poor little frogs we had to dissect and all that. Yeah, they were that the heart, the human heart, it's a biomechanical pump. And we study the anatomical heart, and we understand it using this idea of a pump. And the model is that this pump pumps blood and oxygenates our muscles and animates our body. But now Husserl would have us, and I would have you think, is the heart really and truly, really a pump? And what Husserl and Pat Deegan are going to say is, well, it's not just a pump. And that's why I conjure up the ultimate romantic Romeo and Juliet and ask the question, what is the human heart before we learned in the third grade that science tells us the heart is a biomechanical pump? What is the human heart? What is this human heart? And the human heart, the heart that we know way before we learned that a scientific model for the heart is that this is the heart that can be broken. This is the heart that can go hard and callous. This is the human heart that can become cold-hearted. This is the heart of a child that can soar. And also it's the heart of all of us that can lose heart and be hurt and broken. So from the perspective of the lived heart, the human heart, the idea that the heart is a biomechanical pump, frankly, is reductionistic, right? It seems to be so much more in some ways than that, right? It seems a little simplistic. But what I would argue is that, and Husserl would too, that these represent two ways of knowing our world. Knowing through science is a really powerful and important way of knowing. But knowing through lived experience is another valid way of knowing. Okay? One way of knowing is not better than another way of knowing. However, when brought together, these two ways of knowing can complement one another. Now, let's be clear. If I was going in for open heart surgery, I do not want William Shakespeare, Romeo and Juliet operating on my heart. No, I don't, right? I want the very finest that scientific know-how can offer me. Yes, right? Knowing through science, right? But what I also want is that I want my cardiologist or my cardiac surgeon to have a fully human heart. So when he or she comes to my bedside, they can touch my shoulder and say, how you doing? And mean it. I don't want an AI bot at my bedside. I want the human heart there with me. So not so much in the ER, in the operating room, but yes. All right, let's do another example. Clinicians, for instance, those of us in the room today who have clinical backgrounds and that work on clinical teams, we're informed by science. We've read the studies, and science says that auditory hallucinations are often, not always, but often, a symptom of a mental illness. And we can even do brain scans of a person and get to witness, in terms of imaging, what it's like to have an auditory hallucination and what parts of the brains these experiences are emanating from. That's something. But again, from the vantage point of the lived experience, we would ask, what is hearing voices before science tells us it's a symptom of mental illness, right? And what we might learn and what we might realize is that sometimes hearing voices can be a powerful experience. Sometimes hearing voices is not about mental illness at all, but is about a kind of spiritual experience. And all we have to do is look at the prophets and of our religious traditions to validate that it's not always about mental illness, right? It can have meaning and purpose. So two ways of knowing are present on our teams when peer specialists are working on clinical teams. There's knowing through the applied clinical sciences, and there's knowing through lived experience, sitting side by side in the same room together. And what I want to share is that sometimes the wisdom of the lived experience complements the clinical knowledge. Sometimes it definitely challenges um, uh, clinical knowledge and know-how. And sometimes it does both at the same time. And I want to share an example of that with you right now. So, of course, names and details have been changed, but this comes from a real scenario. This is Myra, and Myra is experiencing active psychosis, and she's beginning her work with the team. Um, she is working currently on a job and tends to work alone on her shift at night, and she's been able to keep the job for a couple of years. She has two previous hospitalizations, and her by her own self-report, is using alcohol. Her diagnosis is alcohol abuse as well as unspecified psychosis. She's receiving care with an early psychosis team. Um, she does experience medications as helpful, but can be very inconsistent with oral meds. And she is willing to talk with the team about the possibility of an LAI, but they haven't got that far yet. She routinely feels very, very afraid. She's scared for her life. She believes that strangers want to get her. And between she sort of has an inverted day-night schedule. Between that and the fears that she's struggling with, she's the team fears she's quite sleep deprived. She is in good connection and very consistent connection, values her work with the primary clinician. And she shares in that context that she's considering buying a knife to protect herself. And she also is recommending that her therapist buy a knife as well. So this care consult is presented, and of course the team is concerned. And they do some really fine clinical work around this in the moment. So they start by talking about what safety planning is going to entail in their work with Myra. The clinical team discusses and sort of pushes up the agenda, the shared decision making for the long-acting injectable. They start talking among themselves about how to introduce a harm reduction approach for the alcohol use. The therapist talks about CBT for psychosis. The C's gets involved and starts thinking about financial security, and might there in fact be some daytime jobs that might help her improve sleep and be able to maybe begin to reduce how the sleep deprivation may be affecting her. And then the peer specialist chimes in, and it was so amazing to hear this. The peer specialist shares with the group, "I grew up queer and often felt people staring at me, trying to figure out my gender. And that got tangled up in my experience of psychosis. The threat was real. People were staring at me. And in our society, there's terrible violence against non-binary folks like me. I started to explore how to defend myself. I decided not to get a knife because it's illegal to carry one. I settled on pepper spray, and I took self-defense classes. Myra might be interested in exploring how she can safely defend herself, too." Wow. I think this is an extremely powerful example of how knowing through the applied scientific clinical gaze and knowing through lived experience can come together in a really optimal kind of way to support individuals in getting the best care possible. And I do think that the idea of, talking to Myra about maybe getting pepper spray and attending some self-defense classes, I think clinically, I was not trained to think that way, right? So that I can imagine that there can be a little, well, that's different, but at the same time, I'm loving it, right? I'm loving where this conversation with Myra could go about becoming more proficient at defending herself should she ever be assaulted. So, lived experience, that's, in my opinion, what it means. And this is a scenario of how it can work together optimally. So I want to take a few minutes. I'll take questions if you have any, but I'd also like to ask if you're willing to share, to tell us about a time when you made an important contribution to the team's understanding of a program participant and how best to work with that individual. And clinicians out there, tell us about a time when a peer specialist shed new light on your understanding of a program participant and how best to be of help.
Folks, you can feel free to raise your hand, come off mute, or use the chat feature.
Hey, I can add a little bit here. I have a participant who, they're going through a lot without sharing a lot. And I just didn't, I think the team, few people on the team had a bit of bias toward them, which I found to not be very healthy or to help them out at all. So I was able to kind of explain from their perspective and point of view what they're going through to kind of humanize them in a situation where I think they were being um, just kind of judged and people had a biased opinion towards them. I think that advocacy helped the situation and calmed everything down.
And I was out one time with a clinician, and we were reaching out to someone in crisis in the community. And I think the police were there, and the ambulance was there, and they were all talking with each other. And I noticed that the person we were there to help was standing by themselves. And I sidled over to him, and I said, "I'm Gloria. I'm a peer support specialist." And I said, what's going on with you? And are you scared? I kind of, your body looks like you're maybe scared. This is a lot of people. And the person said to me, yes, that they were scared. And I said, I get that. This is scary to me, and I'm here to help. And I said, are you wanting help? Do you want to go to the hospital? And the person said, yes. And they had brought out the stretcher thingy. And I said, I tell you what, why don't you take over and hop up here so they physically see that you're doing this? And I'll say, hey, we're ready to go. And that's what the person did. The person hopped up on the stretcher, and I said, hey, and I said, I'll ride with you in the ambulance if that'll help you. And the person said yes. And so I hopped on the ambulance, got buckled in myself, and off we went. And to this day, I remember that.
Oh, oh, you're amazing. Travis, Gloria, wow. That's peer support. That's peer support. Yep. Way to go. Very wonderful story. Thank you. I think one of the things we have to be very careful about as peer specialists is, and I sometimes see it drifting over here where we go, well, we really know, and they don't really know, the clinicians. And of course, the clinicians really know too. And that's the whole thing about knowing through the clinical worldview and knowing, and knowing through science and knowing through lived experience. There are two ways of knowing. There are times when these ways of knowing clash, for sure, right? But a lot of the time, a tremendous synergy and improvement in care can occur when they're working together.
Looks like Lori, you have your hand up.
Yes, I'm a peer specialist as well as work a lot with clinicians. And I have kind of a response to both of the questions you have on the screen. I was teaching a training on what peer specialists are, and I said to any of the clinicians, what is your experience with peer specialists? And the SUD director said, I view clinicians as folks that sit across the table of someone that's in service. And I see the peer specialist as sitting next to them.
Mhm.
And I loved that. That was just like, you get peer specialist. And he mentioned over and over again how there would be a team of clinicians that would be frustrated about behavior, about no movement and things. And then the peer would bring in a different perspective that would cause a pause and a empathy and an understanding. And I just love that. So
Yes, just beautiful. Thank you, Lori, for sharing. Love it.
Pat, in the chat, we have a question from Robert. Says, what kind of questioning is crossing the line for a peer?
Yeah. So a little bit later in the talk, we're going to get into drift. When the peer crosses the line, first we're going to discuss why that happens, and then we're going to give examples and what alternatives might be. So I'm going to put a hold on that question, if it's okay, and get to it a little further down the line here. Good question. Very good. All right, I'm going to giddy up because I can talk, man. I can tell, you can tell I like doing this. All right, let's move on. So to kick off part two here, I want to say that I think that the unique unduplicated contribution of peer specialists on clinical teams is to help deepen the clinical narrative into an actual story, the story of a resilient human being. Peer specialists help teams understand how folks are making sense of their experience. And peer specialists, again, are guided by lived experience, not clinical science models. And remember, just because I have had the lived experience of X, Y, or Z doesn't mean that anybody else has. And that's the weakness of the lived experience perspective, because it's an N of one, right? It's a research perspective of one. So it's both a strength and it's also a grounds for humility, where I recognize that science is based on the cumulative perspective of many people who've been involved in research and what research findings are about. So, in any case, now, when peer specialists join a traditionally clinical team, and that's what's happening that's very unique in history at this time in our peer movement, is we're in forensic facilities, we are in hospitals, we are in emergency rooms, we are, on coordinated specialty care teams, ACT teams, we're in traditionally clinical settings, right? And just by virtue of arriving with our unique perspective, we create a series of disruptions. We disrupt business as usual. Historically, these have been hermetically sealed clinical spaces. And all of a sudden, we show up. And what I'm saying here is we're not showing up to cause trouble. We're not showing up to, cause trouble. But by showing up, we already begin to disrupt business as usual. So I want to go over some of the common disruptions that if you've not experienced, they do happen whenever we join up with a clinical team. The first is that we are the evidence that recovery is real. And what I mean by this is that that historically, in textbooks, clinicians are taught, for instance, that there is no recovery after a diagnosis of schizophrenia. That our goal is to first stabilize and then maintain people in communities who have chronic conditions, right? This is still being taught, current medical schools, etc. And then we walk in the door saying, hi, my name is Pat. I was diagnosed with schizophrenia when I was 17 years old. And guess what? Here I am today. What? And so it does create a kind of dissonance. And so we kind of scramble these theories. The other thing that we do that's important is we're coming in, we're being open about having the lived experience of our own recovery, and that we are not just maintained and stabilized, but we're thriving a lot of the times. And that we kind of inherently raise the bar on what outcomes should look like. Maintenance and stabilization is a very low bar. We're saying, no, we need a life. And that's raising. So the way this shows itself is that clinical staff who are trained traditionally, I'm going to call us traditional staff, it creates cognitive dissonance when you have two competing ideas in the human brain. And the human brain doesn't like cognitive dissonance. What the human brain does when we're present with two conflicting ideas is get rid of one of the ideas, right? And so it creates dissonance. It's an uncomfortable feeling. And sometimes the way it shows itself is that clinical staff begin questioning. In my training, I wasn't taught about recovery. If recovery was that common, I would have been trained to support recovery. Does this mean that my training and my education aren't relevant? These peer specialists, they're great, but they're the exception. They're not the rule. It's unfair to have these higher expectations of some of the people. I work with the really hard people, and they're not like the peer specialists. These peer specialists aren't like the people I work with. And also, sometimes this dissonance can express itself as a feeling of, well, these peer specialists, what are they talking about? They don't have advanced degrees and they lack training. What are they even doing here? I spent, 15 years in secondary school trying to, all right. Second disruption. We blur, as peer specialists showing up on the team, we are blurring the boundaries between health and sickness just by showing up at work. And what I mean by this is that traditionally there have been very firm lines set between the land of the well and the land of the unwell. So I'm going to ask you, looking at this picture, probably from the 1940s, can you find the staff? Look really hard. Right. Well, how are the staff? Yeah. How come we know? Well, first of all, the land of the well, the staff, represented by the staff here, is designated by very official looking uniforms, right? Whereas the patients are in ill-fitting cotton shifts at the state hospital. And also by the roles, not just by the clothing signifying my role, but also what I'm doing. I'm handing out meds for a med check, and not only that, but when you think about it, the idea that there's a place for the well and the unwell is also reinforced by literally some of the architectural layouts of buildings. So you've got your staff bathrooms and you've got your patient bathrooms. You've got your staff lunchrooms and you've got your patient lunchrooms, right? So very clearly delineated. The well are over here, the unwell are over here. Now, more modern times, can you find the staff? I would say it's challenging. Very challenging, right? It's hard. And it's because, in some ways, as the peer workforce is emerging into behavioral health services, the lines between the well and the unwell become more of kind of a slow continuum, right? They're not distinct camps anymore the way they once were. And this in itself sets into motion a rather uncomfortable culture shift, right? What it means is just by showing up at work, right, a clinician might begin thinking, oh, I have a trauma history and I was in therapy. Does that mean now I'm a peer? I can't tell you how often I hear this from people, right? And it's a good question. Does that mean I'm a peer? I've used psychiatric meds, does that qualify as lived experience? I may be operating, and working day in and day out as a psychiatric nurse, but I've taken an antidepressant before. Does that make me a peer? I saw a counselor when I was a teenager. Does that mean I have to tell my clients all about my personal life? I mean, these are real. I mean, they sound a little funny right now because I'm kind of putting it out in that light, but these can get agitating, these questions. I work as a social worker. When I was younger, I spent time in a psych hospital, but that's my private life. Do they expect me now that they got these people in to the team to disclose my personal life at work? I don't think so. So I'm saying this is the uncomfortable disruption that begins to occur. And so what happens is, quite naturally, cultures don't like to shift. Nobody likes to change. Cognitive dissonance can be difficult. And so what happens is, I think, unwittingly and without conscious intention, I think most of the time, clinical staff and other members of the team begin to have kind of a resistance. And the resistance very often takes the form of assimilating the peer into the clinical culture. That without saying it in quite this way, the resistance to this disruptive shift that I'm describing very often appears as, well, if we can get the peer specialist to talk like, act like, think like and learn all the clinical work, they'll just kind of be junior underpaid social workers. And it's a little irreverent, but it's there. And we see the tension all the time. And that's probably the first kind of knee-jerk, what begins to happen in the first months of a peer specialist joining a clinical team. These are predictable, tensions. And so what begins to happen then is the peer, under this influence, begins to experience what I call drift. And that's when a peer specialist begins thinking and speaking and acting like clinicians. But when that happens, the team loses out on our unique perspective. We just highlighted a minute ago in the story of Myra and in Gloria and Travis's, beautiful examples of how when we have that unique perspective from the lived experience expertise of the peer specialist, it can create such a powerful synergy and complement to the clinical work. If the peer specialist becomes clinical, we lose it. Okay, we lose it. So drift is what happens when peer specialists start acting, thinking, talking like, and behaving like junior clinicians. Okay, so examples, and it's important we go through quite a number. Okay, so here is a great clinical model or clinical way of knowing, and this was a write-up for a consult. LM is a Black cisgender female in her early 20s who began working with the team in March 2022. She's bright, motivated, and engaged with the team. She's been experiencing auditory hallucinations prior to working with us. She's currently in college, but unable to complete the semester because she's failing her coursework. Her hallucinations are preventing her from being productive at school. She recently started responding inappropriately, laughing and smiling, to internal stimuli. She presents as distraught and often cries out of frustration with the voices. In March, she was prescribed olanzapine, which seemed to help decrease the intensity of the voices. However, for the past 2 weeks, LM has refused to take meds, stating they are unhealthy for her, and the team is concerned that she lacks insight in this rejection of medications. Peer specialist is of course, in on the care consult and is listening and replies, LM's home from the hospital now, but she still has no insight. I could reach out to her sister to see if the sister would be willing to supervise LM's med compliance. And that's what the peer specialist is offering as something that he could do to support LM in this situation. What's going on here? Drift. Drift is going on here. My thoughts. The peer specialist finds himself in a fixer role in relation to the peer. As peer specialists, our job is never to fix anybody because our peers are not broken. The peer specialist is not transparent and is going behind LM's back to make a plan with the sister. Peer specialists are always transparent about what it is that they are up to and remain focused on the individual's goals. The peer specialist is using clinical language, a term like insight. This is not a term that we use as peer specialists. It's a clinical term. The peer specialist in this scenario is trying to achieve patient compliance with medication. We do not attempt to achieve, persuade, or dissuade compliance with medications. And also, this peer specialist is working on a goal that probably is not the peer's goal. In fact, we kind of know from the scenario that it's not. So a peer specialist in a scenario like this, in order to remain peer, is going to pull back from that drift, right? And instead, sometimes offer a more complex narrative that reflects LM's own lived experience. So when we're at a clinical meeting as peer specialists, we're not just going to become echoes of clinical understanding. We are going to bring the vantage point of the person we're working with, our peer, to the meeting, right? So what this peer supporter does is let the team know some of the voices LM hears are really wonderful. They comfort her and help her believe she's really special. LM's choosing not to take the meds because they interfere with those good voices. She doesn't want to get rid of them. Now that's a narrative, that's a perspective, that's a lived experience of LM that this peer specialist is bringing into the room, right? And it does make the narrative more complex. The original narrative, she lacks insight into the fact that she's ill. And this peer specialist is bringing in a whole nother perspective, the lived experience of LM. Some of these voices are really helpful. They're good. And she doesn't want to get rid of them. So now we have a very different kind of discussion. So lessons learned that peer specialists, we don't use clinical language like decompensate, baseline, or that of lacking insight. Peers never assess peers. Our job is not to assess for suicide, not to assess for stage of motivational change, not to assess. It's not what we do. That's clinical. We do not encourage or discourage compliance with anything. We help the peer articulate their choices and present those to members of the team. And we don't, this is an important one, we don't attribute motive to peers. A lot of times I'll hear a peer specialist say, oh, he's sabotaging the job again. Oh, she's just being attention seeking. That's attributing motive to a peer's behavior. That is not what we do. Okay. Another example of drift. Here's Keanu, and Keanu saying to his peer supporter, look, stories about shamans go way back in my culture. Maybe my visions and voices mean I'm becoming a shaman. Maybe I don't have psychosis. Peer supporter says, man, your doc says you have psychosis. It's not your fault. In order to recover, you have to accept your illness. That's the first step. Okay, this is a common form of drift, right? Well, my thoughts on this is that the peer supporter is telling Keanu how to understand his own experiences, and that's not what our role is. That our job as peer supporters is to support Keanu in developing a personal understanding of his experience, right? And to then bring that or invite Keanu to come himself to the team to present his own understanding. Two things can be true at once, right? I can be having a spiritual emergence, right? And I can be struggling with that emergence at the same time, So we offer a more complex narrative based in Keanu's growing understanding of what's going on. And so what a better response I think might be is, oh, that's so interesting. I don't know that much about shamans. Maybe you can teach me. But there definitely was a spiritual dimension to my experience too. Like I was awakening into a new consciousness. And for me, parts of my experience were beautiful. So being able to affirm that parts of what gets called psychosis can be deeply meaningful, can be profound, and can be experiences of learning and emergence. So peer supporters, what do we learn from this? We need to support peers in making personal meaning of their experience, right? We need to be willing to embrace pretty complex narratives like trauma and spiritual emergence and variations of human experiences. And if we don't know about it, all the better. Let's get our peer to teach us. What is shaman? I don't even know what it means. Teach me about your culture. I'm interested. And that these alternative stories of self really help to deepen the clinical narrative. They really do. They deepen a case study into a human story, the story of a human being who's becoming. And I want to give a special shout out to my friend Sasha DeBruhl for helping me appreciate this dimension of peer support. Coco, she's also struggling with drifting away. So here's what happens. She's in a rural county where she's in a rural county and where most of the meetings with psychiatric care providers happen by telehealth. And it's hard to get an appointment because the clinic books up a month out. And one of the individuals that Coco's working with is named Stephanie, and Stephanie's interested in reducing her medication and maybe stopping it altogether. So Coco supported Stephanie in setting up an appointment to see her prescribing nurse. But like I said, it'd be 4 weeks until the appointment. So in the meantime, Coco began studying websites to figure out how to identify if Stephanie would be capable of reducing medication levels while still being able to make progress in her recovery. And Coco felt that this knowledge will help her work better with Stephanie and others who are prescribed psych meds. But this, I believe, is a form of drift, right? And in particular, I think Coco did a good job of peer work when supporting Stephanie, getting the telehealth visits set up for sure. That was a good move. But she drifted from the peer role into a clinical role when she begins her studies into the peers' readiness to reduce meds, because peers don't assess peers for readiness to reduce meds. And it's the medical team's role to do shared decision-making about starting, stopping, increasing or decreasing meds or supplements or over-the-counter drugs or anything else. And so the role of the peer specialist is to support people in becoming empowered self-advocates who have a voice and a choice in decisions about meds. That's our role when it comes to med. It's not to recommend or not recommend, right? But it's about becoming empowered. And that's what my whole medication empowerment approach is about, which we're going to learn more about down the road. And that what peer supporters can also do that's really helpful is to help folks in finding credible information about meds and supporting people, right? In presenting that information to the provider. Because there's a lot of not so good information out there. Okay, one more. This is Grace. And this is an example of drifting from the peer role into a medical role, which unfortunately is also somewhat common out there, right? So Grace recently graduated from a certified peer specialist training in her state. She was all filled with excitement and great ideas about how to support others in their recovery. And after certification, she got a job with a local ACT team. However, she was disappointed to discover that part of her job included doing weekly med box drops at participants' homes. Every Wednesday, she had to meet with the nurse and then pick up newly filled, locked med boxes. And she stacked the med boxes in her car and drove around the county, delivering the boxes to program participants' home. She was always careful to check her paperwork to make sure she gave the right box to the right person. She had other duties as well that included sometimes transferring urine screens from participants and delivering them to the nurse, and doing weight and blood pressures when the clinic got busy. And Thursdays were a particularly busy day because the ACT team gave injections before distributing individual checks and entitlements. And Grace's job often involved going around the community on Thursdays and picking up folks for the long-acting injectable clinic. Oh dear, not good, right? This is not good. That med box drops, straight out, are not peer work. Transferring urine samples is just not peer work. Taking vitals is not peer work. Transporting people to med clinic is not peer work. And Grace is, in fact, performing tasks of a certified nursing assistant, okay? And so if we find ourselves in any of these kinds of scenarios, we really need to challenge the legitimacy of this kind of work, because sometimes it does happen out there, and we really need to go to our supervisors and say that this is not peer work. So what would peer work look like that Grace could provide and that would be meaningful? Well, she could help participants understand their legal rights and prepare a psychiatric advance directive if desired. She could help participants access credible, scientifically sound information about psych meds and help the participant prepare questions for the docs. Could listen if the participant is angry about forced drugging and voluntary measures and validate the peer's perspective on that. Grace could help the participant identify personal medicines and things they can do to help them get the life they want. They could go to med appointments with the participant. They could support the participant in developing their own story or understanding, focus less on what's the matter with me and more on what happened to me, and represent that story when working with the rest of the team. And another thing I hope we never forget in working with peers is that sometimes it's a great idea just to have some fun. And in having a little fun, what we're doing is actually very meaningful. It's not shallow and superficial to go out and kick a soccer ball around or to go out together for an ice cream together, because what we're doing in doing that is showing that recovery can be right now. Recovery doesn't have to be that thing that's way down the road out there in the future at some point when I'm all better. No, recovery can be in the laughter that we're sharing right now. And that's the power of peer support. We get to do it right now, right? Right. So what's the key to helping our peer specialists avoid drift? And that is by using peer-developed tools, which share very similar values. So just very briefly, we're very blessed in this country with great tools. For instance, the 8 Dimensions of Wellness is still and remains. Peggy Schwarbeck herself, an ex-patient and peer, she developed the 8 Dimensions of Wellness. The Icarus Project and those great folks developed transformative maps, transformative mutual aid practices. This is a free download, which are fantastic and helps us look at ourselves and this thing that gets called mental illness in a much more holistic kind of way. Fabulous peer-to-peer stuff developed by peers. Pat Deegan, certified personal medicine coaching, which we're thrilled to be bringing to Washington State. We have a worldwide community of certified personal medicine coaches, and we're thrilled. We're going to get that rolling in Washington. And then, of course, we've got all kinds of alternatives, the alt to suicide groups, training programs, community forums and alternatives to suicide, just new and safer places to talk about maybe just feeling tired or, just places where peers support each other, even through periods of feeling down, and our Hearing Voices Network. So in closing, and we're going to go to questions, authentic peer support. It's extraordinary. And I'm so proud of us and how far we're coming in our profession. We've got a long way to go. But it's about love. It's about outrage. We can't come to work, get paid for singing, "The inmates united will never be defeated." We can't go there and work. We can't be activists at work. But we can be advocates at work, and that our advocacy comes out of a place of outrage. It also comes out of a place of deep love. And I just celebrate that and celebrate you. And so if I just ask and put out here a thought, have you ever seen drift of peer specialists into clinical language, clinical thinking, clinical responsibilities in your work? And what, in your opinion, helps us remain peer? I'm going to stop the share.
I'll just say, I think the same things that you're speaking on: empowering, information, encouragement, all of those things are relevant in helping not only the individual peer specialist, but the clinicians that they work with.
Yes. Thank you, Lori.
I was going to say, I've been doing this a while, and the way I learned is by drifting, recognizing I was drifting and realigning myself. And I wanted to say other peer specialists out there, especially new young ones, because I remember when I was first starting out, I was trying to figure out who am I and what is my role here. And I was working in crisis response, talk about confusing. And I learned it in many different ways. Sometimes it was another peer that I was working with who said, "I thought you were supposed to be here for me." And I had to feel my face go red and get quiet and shut up and say, "You're right." and rethink what was going on. So if that happens to you, just know that it's part of growing and being human and being a peer support specialist, that the important thing is to hear it and see it and learn from it. I just think it's easy to feel ashamed. I know that I was at times when I have, and I hate to say it, I still drift upon occasion, and I have to like reel myself in and say, this is why I'm here. And thank you, Pat, for that intersection of love and outrage. I'm going to use that in one of my classes that I teach about consulting with a peer support. So thank you.
Go ahead, Melody.
Yeah, I just want to say for me, kind of what was just said by Gloria, I I was sabotaged a little in my first job because they taught us to write notes in a clinical way. And so I really had to unlearn a lot of those behaviors and really, catch myself. Um, from saying, oh, that was a young voice, from saying things like, peer presented as, and, just talking in that way. What kind of clothing were they wearing? Were they disheveled? Were they? So yeah, just like Gloria said, just really having to police myself and give myself grace and take it from there. Thank you.
I love that, Melody, that kindness to ourselves and knowing that everybody makes mistakes and we can learn. Part of what can happen if the team, particularly the team leader, understands drift and understands the force that puts drift into motion, this cognitive dissonance, this disruption of business as usual. The team leader can do a lot to bring, because the peer specialist is experiencing pressure to drift. They're not just drifting because they're making mistakes. They're experiencing, like you said, here's how you write a clinical note. But I'm not a clinician. I don't write clinical notes.
Right.
I write peer notes, and preferably I write them with the person I'm working with. So I guess an important message is here. There's so much, and it would be a different lecture to talk about what the supervisor, the team leader, can do to take
Yeah.
that pressure off, help to take the pressure off the peer.
Yeah, I also worked with someone and she recently switched organizations because she got so much pressure from her supervisors, like to do assessments, and even though she would push back and say, no, that's not part of my, part of what I should do as a peer, it came to, either do them or you're not doing your job. And so she
Yeah,
left.
yeah, yeah.
It's unfortunate.
Thank you for sharing that. That's good. I want to give a brief shout out to my friend Stephen Williams, who I see out there.
Yes, I saw he had his hand up, I think.
Warrior just like said exactly what I was gonna say. And it's like, man, I was drifting the second I started in the field because I came into it with the background that I have. And so when I started working in systems, I felt like I didn't belong in them. And so I was really open to suggestions from people that once had a position of power over me when I was serving systems. It took me a long time to start feeling like an equal team member. And when I look
Yeah.
back on that, I think I could have started feeling like one a lot sooner if I had like allowed myself to kind of feel that way. And like that's one of my like learning lessons in my career is not putting myself in a box when I show up on teams. That's a
Mm,
hard lesson for a lot of peers.
I love that.
I personally, and I'm interested in your thoughts on this, folks, is that I think it can be helpful to know what some of the big clinical words mean, um, so that we're not in the dark when the conversation is happening clinically, um, but that we're not going to use those terms, right? But it can help to know what it means. Do you agree, disagree, thoughts? I see head
I
shaking
agree.
hands.
I think too, and the peer that you're supporting wants to know what that word means. It's good if we know so we can explain to them.
Yeah.
Recognize that we are at time, Pat. And so I just want to thank you for this really amazing presentation. And I want to thank all of you for attending today, for your wonderful attention and engagement with us. The slides have been attached in the chat as well as the TMAPS guide that Pat referenced earlier in her slides. The Healthcare Authority has recorded this, and so we will make that available to all to those of you who would like to watch it again, or maybe for friends that didn't get to watch it. So thank you, everybody. And Pat, any last words from you?
Just thank you. It's a delight always. I love Washington. You guys rock. Thank you.
Well, we think you rock, so we welcome you here anytime.
Okay,
Yes, Washington loves you back.
good. Thank you all. Take care. Bye.